Good day, my dear postgraduate students. Welcome to Recent Advance 25. The topic for the day is Fibrosing Interstitial Lung Disease. The authors are given below, and the importance of it is there in the enclosure. This per se is an important postgraduate question, more so that it had appeared in the Recent Advance 25. Let us see what the topic has in store for us. As usual, think of the subheadings. The subheadings will take you to the answer. In this case, apart from other things, these are important. There are certain rare manifestations or specific causes which we should be having in mind. Also, the radiology. These things, if we do add up, it will get more credit to our answers. To the introduction. Interstitial lung disease by itself, it is a broad and a heterogeneous group of disorders or diseases. There is inflammation and fibrosis to varying extent in different etiological causes. Specific changes, for example, granuloma, might be present in certain conditions. Those specific changes you people should mention. And all the changes that we are talking about take place in the interstitium. The authors say that the prognosis is overall good, but then there is also a permanent damage that occurs. What are the types? Now, this is a plethora of terminology which you need not memorize, and whatever is probable for a common man to recollect will do. Idiopathic, for example, connective tissue, hypersensitivity. Pneumoconiosis, we already know. Cryptogenic is another rare variant, and acute interstitial pneumonia is one of the earlier stages of it. So, this is just to show that there are varying terminologies which are being used, and when we get any such thing, we need not be bewildered. The answer will take care of itself. Such has been the introduction by the American Thoracic Society for Interstitial Lung Disease and the European Respiratory Society. What they had observed was there is going to be an impairment in the lung function and worsening in the quality of life, and early mortality, definitely a crippling morbidity. So these are the observations of these two bodies. Coming to the pathophysiology, the next few slides will be important because it deals with the pathophysiology, which is not very difficult provided you concentrate. There is going to be a progressive fibrosis. There will be the proliferation of the fibroblast or the fibroblast along with the myofibroblast. The laying down of the extracellular matrix. These terminologies I have also used in my connective tissue states. Kindly go back to that class, you will be able to understand it easily. There are cellular interactions and inflammation. You find that there is an epithelial injury and an endothelial injury. What am I talking about? You will see in the next diagram. So, when there is going to be an epithelial injury, the type 1 pneumocyte is destroyed. There is a proliferation of the type 2 pneumocyte. Also, there is an endothelial injury and a coagulation cascade. I'll be telling you now. What the authors say is the etiology can be basically genetic or environmental, or sometimes they say epigenetic. It is a group of disorders that have been concurrently inherited. Infective. It can be because of re-epithelialization or re-endothelialization. So these are certain terminologies which we will be having in mind. It is not difficult at all, I promise you. Look at this picture. So this is the alveolar space and this is the interstitium supporting a capillary. In the capillary, I have got the endothelium. In the alveolus, I have got the pneumocyte, the epithelium. Type 1 is more flattened, type 2 is more aggressive. That is there. What happens is whenever there is any form of an injury, there can be a destruction of the type 1 pneumocyte. Progressively, there can be a proliferation of the type 2 pneumocyte, which will pave way for the various release of mediators and the inflammatory process. That is one thing. So ultimately, there can be fibrosis, fibroblasts. Similarly, you find that at the other end, whenever there is going to be a damage to the capillary endothelium, there is going to be a seepage of blood. And blood outside a blood vessel is considered foreign. There will be a coagulation cascade that is set in motion. As a result of which, ultimately, there will be fibrin formation. So, look at this one. You get fibroblast from one side, laying down the matrix, and also the fibrin deposition. Both of these will lead to the interstitial lung disease. Have this in mind. This is a beautiful diagram for us to recapitulate the entire discussion so far. And we need someone to overview the situation. That is what the leader says over here, and probably there is another person who is overviewing it. An overview is a kind of a recapitulation, and this is a superb picture as such, a flow diagram. The interstitial lung diseases, when it is in this form, I can recollect faster. There can be exposure related, which can be occupational, environmental, and so on. It can be idiopathic. The cause is not known. Connective tissue related, such as scleroderma, rheumatoid arthritis, Sjogren's, and so on. Sarcoidosis, again a disease of unknown etiology. Miscellaneous or others, vasculitis, Langerhans histiocytosis, eosinophilic pneumonias, and neurofibromatosis. Major can be idiopathic pulmonary fibrosis, cryptogenic, non-specific interstitial pneumonitis, respiratory bronchiolitis, desquamative interstitial pneumonia, and acute interstitial pneumonia. This is a wonderful flow diagram that you people will have to memorize. There is no other way, thanks to Alzheimer, that I am getting into. So I will not be able to remember the rest of the text, but this will be sufficient to take me to the various answers. As I told you, there are too many. We will not go into it. But then Wikipedia has been a wonderful source of information in the compilation. So idiopathic is one for which the cause is not known, and it has been mentioned by the American Thoracic Society under various things such as idiopathic pulmonary fibrosis, desquamative interstitial pneumonia, respiratory bronchiolitis, so on and so forth, which we had seen in the earlier flow diagram. This is for a completion of how good a work Wikipedia had done. Courtesy, recent advance 25. This is again a wonderful picture. Now, as I had been mentioning you, this has been the alveolar space. This has been lined by the type 2 epithelial cells of the pneumocytes. Type 1 is being destroyed. Type 1 is getting proliferated. Also, you find that there is an interstitium, there is an endothelium which gets injured. All lead to the proliferation of the fibroblast, and any chronic injury can lead to the release of the various mediators, such as transformation growth factor or tumor necrosis factor, interleukins 4, 5, and 13. So these are all over there. And there is a play of reactions. This we had already seen again in recent advance 25 under the lung injury in COVID. The vascular barrier is broken. There is a deposition of the fibrin as well. All of this will be leading to interstitial fibrosis. Look at this one. These are the fibroblasts. Now, the author analyzes what are the sources of these fibroblasts or fibrosis. And he mentions it can be from the fibroblast itself. After all, whenever there is going to be any injury, there is going to be a proliferation of fibroblasts. There is fibrin. And the fibroblasts themselves can be derived from the stem cell. After all, the lung is not a connective tissue. There can be a mesenchymal metaplasia. And epithelial endothelial cell also can lead to fibroblast migration and proliferation. So this one you people should mention for the various sources of the fibroblastic proliferation. There is also the genetic predisposition that has been mentioned, as well as the cigarette smoking over here, which can be causes for it. So this is a beautiful flow diagram courtesy directly from Recent Advance 25. And this slide is again a summary of the process that I had been mentioning. You can mention it under the subheading of molecular basis. The same picture is over here, and this is the source of my reference. The secondary causes. This again is a list continuing from the Wikipedia. As I told you, there can be idiopathic or the primary causes. 2 secondary causes, which can be connective tissue, autoimmune disorders, such as all this: sarcoidosis, rheumatoid arthritis, SLE, and systemic sclerosis. Polymyositis, dermatomyositis are there. And any of the inhaled substances, pneumoconiosis. If you go to your Robbins, he says, under the pathogenesis, how ultimately these lead to the fibrosis in the lung. Inorganic material, silicosis, asbestosis, all come under the pneumoconiosis. And you all will not forget the coal workers pneumoconiosis, wherein there is going to be a massive interstitial fibrosis suffocating the patient to death. Hypersensitivity and drug induced. Sometimes chemotherapeutic drugs also can be causing cigarette smoking. So this should not be difficult. 10 is over here because it has been taken from Wikipedia straight. And the list continues. It can be because of infection. This I would like you people to kindly remember. The coronavirus, COVID 2019, atypical pneumonia, mycoplasma is supposed to be one of the causes. Pneumocystis pneumonia, in the case of AIDS, tuberculosis, chlamydia, respiratory syncytial viruses. At least 3 of this you people shall and will mention. Malignancy mainly lymphangitic carcinomatosis or lymphomatoma. And children, there can be any diffuse developmental disorders, abnormalities with deficiency in the development of the alveoli. Maybe lack of expansion or the surfactant. Undefined cause. And there can be the hyaline membrane disease. These things we shall be having in mind. There is something called the usual interstitial pneumonia or the idiopathic pulmonary fibrosis. So these are the things. This is the most common, and it is chronic, progressing slowly, occurs in the elderly, though it has been reported in children and younger people. Men more common than women. They say that there might be a defect in the telomerase and the telomerase pathways, particularly in children, leading to fibrosis. And cigarette smokers, gastroesophageal reflux disease has been quoted one of the causes for this interstitial fibrosis. And viral infections, I've already given you the list. Now, let us come to this ground med. Wonderful picture from them. So I find that the lung, it is appearing spongy in some areas, but in some areas it is pale, indicating that there is some amount of fibrosis. And maybe here there is a peribronchial consolidation that is over there. So I am able to see some spongy areas. Some areas are slightly distended. We'll come to that later. But overall, I would feel that it is somewhat in between a lung and a liver in appearance. Pneumocystis. This is what is happening over here. So you find that there is reticular interstitial fibrosis. So if you observe it carefully, there will be fine fibers that are traversing both the lungs. Classical of it. This is the reference, and one of the patient's name is also here, thanks to Wikipedia again. This also. So this is an autopsy space. So in this one, I'm finding that there are some distended spaces. But then can I call it bronchiectasis? Perhaps yes, perhaps no. Bronchiectasis usually it is a permanent irreversible dilatation of the bronchial tree distal to the second degree of division. But then it should not be more than about 0.5 millimeters to, that is the maximum, from the subpleural region. So it is not extending up to the subpleural region. Therefore, I cannot really call it a bronchiectasis. It is a pulmonary fibrosis, which in turn is causing a stretch of the bronchioles and the alveolar spaces. And this is the reference again. And look at this one. I cannot call it a lung at all. These are the alveolar spaces. Normally, the alveolar spaces are all back to back in array. And there will be a thin strip of interstitium with the capillaries not usually seen. But here, I am finding a wide zone that is separating the alveolar spaces. And I can see the proliferation of the fibroblasts. There are also the small lymphocytes which are over here indicating inflammation. And maybe occasional eosinophilus present. So this can be a typical picture. You can appreciate the rigidity of the lung rather than the collapsing nature. A honeycombed appearance. The honeycomb, this picture is given here just for a comparison, but I feel that this can be compared. The honeycomb can be compared with this. So I find that there are multiple distended spaces which are quite stiff, and in between will be the fibrosis. A classical radiological finding I'm finding in both the lungs and almost involving the upper and the lower lobe. What can be the clinical manifestation? The patient has a dry cough, exertional dyspnea, compromised lung function. Pulmonary function test will be abnormal. And when it is persistent, it can lead to a left heart failure, restriction in the lung, and in the diffusing capacity of the oxygen. So this is the CT scan showing the gross honeycombed appearance. So the investigation that you people will have to do will be maybe the assessment of the markers, maybe the assessment of the antibodies in the serum, the radiological picture, as well as any of the mediators of inflammation. Biopsy, of course, is supposed to be a gold standard. What is the pathogenesis again? This is again a simplified version of a flowchart which you people can follow. It can be exogenous or endogenous, dust, fumes, etc. It can be autoimmune, drugs, infection, radiation, and all of this will lead to microscopic lung injury. And they are separated spatially. And in some cases, it heals. But when it is going to be persistent, there will be a fibrosis separating the alveolar spaces. So if it is intact, there can be a normal lung homeostasis. And you find that in wound healing, there can be other things. I mentioned the telomerase and its abnormalities. These can interfere. Therefore, there can be a lot of fibrosis resulting in pulmonary fibrosis. A superb flow diagram, I think it is enough for you people. Okay. Pictures I have chosen, I have done it with great care. It will pay dividend. So this again, I find this is a lung which is having bullous nature. It is almost like a hobnail pattern of the liver. Also, in a case of chronic pyelonephritis, you find that there will be irregular oscillations of the kidney. Whether it is going to be a cirrhosis of the liver or a chronic pyelonephritis or a case of interstitial lung disease, the basic element is going to be fibrosis. And whenever there is fibrosis, you find that the intervening parenchyma will be bulging. And this is the external surface. And this entire section of a lung has been cut. This is called as a Gough-Wentworth section. So in which I am able to see distended spaces, which are again being widely separated by means of fibrosis. And the credit goes to Leslie. This is again a beautiful one. I can appreciate the honeycombed appearance over here, and there is a marked interstitial fibrosis, inflammation, peribronchial or bronchiolar inflammation is prominent in some cases. And in this case, it is almost normal over here. In some cases, there is a marked interstitial fibrosis and there is a so-called distension. This is again a honeycomb picture which is being reflected in the CT scan or the MRI. So, because of the traction, there can be bronchiectasis, honeycombed appearance, interstitial fibrosis, peribronchiolar inflammation, and a ground glass opacity in general. So, this is what we people are supposed to note down. There has to be a clinico-radiopathological correlation. Idiopathic. Histologically, idiopathic, non-specific interstitial pneumonia. There will be a homogeneity. And depending on the predominance of the histological form, there can be a cellular type or a fibrosing type. You find that there is less activity of the fibroblastic foci over here. Ultimately, there can be an organizing pneumonia. Organizing means there is fibrosis. You take a lobar pneumonia, there will be a stage of congestion, stage of red hepatization, gray hepatization, and resolution. But if the infection is going to persist, there will be organization. Honeycombing is quite rare and the lung architecture is in general present. That is why the authors have said the prognosis is good in most cases. The connective tissue disorders, I have already mentioned it under the classification. These are the disorders over here. And the common denominator for all these will be immunologically mediated. There can be spectrum of changes. Blood vessels will be involved, vasculitis. And there will be a vasculopathy that is seen over here. Nodules are present. It can be a nodule in a case of sarcoidosis. And the serum will be showing circulating antibodies, which can be demonstrated by means of a serological profile. So this will be important. And please do remember, take SLE for example, you find it as a multidisciplinary responsibility. And therefore, a correct diagnosis will be essential. Tuberculosis can also produce fibrosis. But if I am going to treat it with steroids, that is the end of the patient. So, fibrosing hypersensitivity pneumonitis. Hypersensitivity means there is a kind of reaction. Always there will be a vasculitis over here and then there is a perivascular inflammatory infiltrate. Look at this line over here. There is an area of pale fibrosis that is present. The symptoms are the same over here. It can be because of fungal, bacterial, viral, or any of the animal material reactivity. The histology is of great importance. Apart from the other things that we had mentioned earlier, histology is a gold standard in making the diagnosis. Granuloma, giant cells, cholesterol, if you are lucky, you will be able to find. So this again, the reference is over here. Please do remember. There is an antigen that is entering. This is the alveolar space, the type 1 and the type 2 pneumocytes over here. You find the moment it is there, as well as from the capillaries, there will be the inflammatory cells that go in, and there is a plethora of mediators which are being released, such as tumor necrosis factor, interferons, etc. And these might lead to the formation of granuloma, or there can be the various chemotactic factors producing the fibrous proliferation, pneumonitis, etc. And the T helper cells are supposed to be playing a role in it, and short telomeres, aging can also affect. This particular diagram is logical, simple, and the credit goes to this reference. Sarcoidosis. Not much to go into except that Jonathan Hutchison was the person who discovered it first in 1869. And this is a case of mediastinal enlargement. So the lymph nodes near the mediastinum or the hilar region, they are getting involved. It is basically a disorder that involves the lung and the mediastinum with a high morbidity. R is missing over here. Common in USA, less common in countries like India. It is self-limiting. Granuloma and fibrosis can be seen. Pulmonary hypertension can be one of the causes. Look at this one. There is a nodule that I'm seeing. Not only is there a fibrosis, but well circumscribed or delineated nodules are seen. And I might not be very lucky to see a well-defined granuloma with the asteroid and the Schumann bodies. Pulmonary Langerhans cell histiocytosis. This per se is an important question for us. We'll deal with it at a later date. It is only for your mentioning. And this picture is also taken from elsewhere. There can be a proliferation of the histiocytes as well as the eosinophils, which can be present. It is a subtype of the dendritic cell, and a MAPK pathway affected by the BRAF mutation is brought into action. There is a T cell mediated cytotoxicity that is seen, and all this will be leading to the activation of the matrix metalloproteinases. This responds to the steroids. This will be leading to the formation, laying down, as well as the removal of the matrix. This picture is given for two purposes. One, I am able to see the honeycomb appearance of it. There is an interstitial fibrosis. Externally also, I am able to see multiple blips as the nodule in a case of cirrhosis. And that is because of the interstitial fibrosis. This picture we have already seen, thanks to Brownman. This is again from a slide collection of late Dr. Charles Kuhn from Brownman. So, massive interstitial fibrosis. The patient is almost suffocated. The lung has got an immense capacity for oxygen, but imagine what this lung can carry. So, obviously, the patient will be going in for a left heart failure. And this is again the interstitial fibrosis, and this is a bronchiolar epithelium as well as the vasculature that is seen. There is a massive interstitial fibrosis. This is a reference for the next picture as such, and which is this. So it is again a wonderful compilation that is given over here. It can be for various causes such as viruses, environmental, gastro, esophageal reflux, immunology, drugs, etc. Any of this you find, there will be kindling the various reactions and the mediators. Fibroblastic proliferation is there. There can be a destruction of the alveolar wall. So this is being laid down. There is a fibrosis that is being caused. Also here I find that there can be damage to the blood vessels, formation of the fibrin, and all these together will be leading to a massive interstitial fibrosis over here. There is an exaggerated extracellular matrix accumulation, lack of degradation, and progressive lung remodeling. Finally, you can get a stiff honeycomb lung. Easy to draw. So this is again one of the slides. There can be the progenitor cells. It is almost a summary. Fibroblasts can originate from any of these things. They are being recruited, they are being brought to that particular region. And there can be the kindling by means of the inflammatory cells such as the T lymphocytes. Also by means of the B cells or in autoimmunity. There is a proliferation of fibroblasts. They may be converted to the myofibroblast or vice versa. There is a laying down of the extracellular matrix, and finally there is a fibrosis. At the other end, in the interalveolar spaces, I am finding the vascular injury, endothelial activation, which again can lead to fibroblastic proliferation. So this is again the reference for it. Always, dear students, it is this kind of flow diagrams that will fetch you the marks. I hope I had reasonably covered the various causes for the interstitial lung disease, what can be the clinical manifestation, the radiological manifestation, how the pulmonary function is being compromised with, what are all the mediators, and what are the primary and the secondary causes, infective and the non-infective causes, connective tissue disorders, which can lead to interstitial lung disease. And of course, rarest of rare, we can mention the Langerhans cell histiocytosis also. We are made wise not by the recollection of our past, but by the responsibility for our future. I do not know why I put this quote over here, but then, according to me, G.B. Shaw, George Bernard Shaw, is a genius who has always been admired by me. Thank you for your patient listening.